Hello and welcome to the Docera Clinical Education and Medical Specialties Podcast, formerly the Clinical Care Options Podcast. I'm your host, Zachary Schwartz. This is the second of 3 episodes from our live event, Raising the Bar, Innovations in PBC Care. In this second episode, Dr. Chris Bowlus takes us through the new agents for second-line treatment of PBC. We then explore a case study with his co-faculty, Dr. Aparna Goel and Dr. Aliya Gulamhusein. To follow along with the slides, visit the show notes. Now let's get started as we turn things over to Dr. Bowlus.
So we've talked about what the targets might be. Let's talk about what the evidence is for these second-line agents that we now have available. So what are our second-line treatments that we have available? So they're classified here into basically 4 different groups. So we have the fibrates, which actually are PPAR agonists themselves. And then the approved therapies include obeticholic acid, which I think you all know is no longer available here in the US or Europe, though it is available in other countries. So still a potential option for some people, perhaps in the audience here. And then we have the 2 new agents, Elafibranor, which is a PPAR alpha delta agonist, and Seladelpar delta specific agonist that were approved just a little over a year ago. In terms of off-label use, of course, Bezafibrate has been used extensively outside the United States. Fenofibrate is available in the US, and there's some limited data on it, but just so everyone's aware, there is a label warning in its use in PBC for what that's worth. There are other PPAR treatments in clinical trials. A phase 3 trial just recently completed on seraglitazar. So there may be more players on the market in not too distant future. And there's some interesting results coming out with some other therapies. And I'd highlight the CMP 104. This is a nanoparticle that is coated with mitochondrial protein that induces the PBC, the anti-mitochondrial antibody. It's the actual epitope. And the idea here is that you're going to induce tolerance to that. So it's trying to get at the underlying immunopathogenesis of PBC. And there's some promising early stage results on that, some of which are being presented at this meeting. But what do we have today? So today what we have is really based on 4 phase 3 trials that I'm going to review for you. And the first one that set this all up was the POISE trial. And this is really, I think, the landmark study that set the design really for all future trials. And so this was a double-blind, placebo-controlled trial of patients with either an inadequate response to URSO or who were unable to tolerate URSO. So the majority of these are patients that had an inadequate biochemical response, which, as we heard earlier, was defined as having that alk phos greater than 1.67 or about 200 at baseline. And the response criteria was to get that alkaline phosphatase below that 1.67, but it also had to be at least a 15% reduction, right? So you couldn't start just above it and then just get below. It had to be at least that. And there had to have a normal bilirubin. Now, most of these patients entered the trial with normal bilirubin, so that was really not an important part of the response criteria. And then as you can see here, then in the double-blind phase, patients were randomized either to receive obeticholic acid at 5 milligrams with the option to titrate at month 6 up to 10 milligrams, depending on their response and their tolerability, or treated with 10 milligrams throughout, or placebo in the orange. And by the end of 1 year, about 45% of patients achieved that biochemical response compared to less than 10% in the placebo group. And then there's open label extension, and you see the placebo group catching up. And then you look at the alkaline phosphatase changes, you can see this relatively rapid reduction in the alkaline phosphatase in the treated groups compared to placebo, and it remains durable, and that's been seen, throughout. So these were the results of the OCA POISE trial that led to its approval. Unfortunately, the approval process is what's called accelerated approval, which I'm sure many of you are aware of. So it gives the opportunity to market the drug, make it available to our patients commercially, but it requires a confirmatory trial to show that it actually improves patient outcomes. It reduces clinical events. And so the COBALT trial was set up to do just that in patients with more advanced PBC, to randomize them to either placebo or obeticholic acid, and then look to see if it could be demonstrated that obeticholic acid actually prevented hepatic decompensation, liver transplantations, or death. However, as you can imagine, it's hard to enroll in a trial like that when you have the medication available commercially, as well as the fact that patients in the trial could be functionally unblinded by just looking at their alkaline phosphatase and seeing that it's not going down and assuming they're on placebo and then disenrolling from the trial, and that's what happened. And so the Cobalt trial was terminated due to lack of feasibility. Now, to try to demonstrate that there was actually an effect of obeticholic acid on survival, patients that were treated in the POISE trial and kept on open-label treatment for up to 6 years were compared to 2 different external real-world controls who had been treated only with urso. And in both comparisons, patients treated in the POISE trial with obeticholic acid had an improved transplant-free survival, and in one group, survival-free of hepatic decompensation compared to the historical controls, suggesting that there was some real benefit, though there's always the possibility of confounders not being accounted for in these analyses. So the other issue we have with obeticholic acid, of course, is that it induces pruritus, and there's some concern about its use in patients with advanced liver disease. So in the end, though, that's not available for us today in this country, but as I said, appears to be available for others. And I think many of us still have patients on obeticholic acid who have done quite well with it for a number of years. So now enter the PPARs, and there are 3 different isoforms of the receptor, alpha, delta, and gamma, and have different effects, which is interesting because, as we'll talk about in a minute, all these PPARs seem to have some effect on cholestasis regardless of their target specificity. So the PPAR alpha, like fenofibrate, it targets mainly hepatocytes, delta, hepatocytes, cholangiocytes, Kupffer cells, and stellate cells, and then the gamma Kupffer cells. And the mechanism of action is thought to be primarily reduction in the synthesis of bile acids, along with reductions in uptake and increase in detoxification. There's also some increase in production of phospholipids to make the bile more cytoprotective, and then also some improvements in inflammation through downregulation of cytokines. And as you can see here, the different PPAR agonists have different specificity, with Bezafibrate being pan-PPAR agonist and are activating alpha and delta, and then Seladelpar just delta. So the phase 3 study of Bezafibrate was in France, and this study design, it's important to recognize, is a little different than the POISE or the other trials we're going to talk about. It included patients that had an alkaline phosphatase greater than 1.5 times the upper limit of normal, so a little bit lower threshold, so they had lower alk phos coming in. But then the response criteria was greater. They had to have normalization of alkaline phosphatase, bilirubin, AST, albumin, and prothrombin time. So you can't really compare the response rates here, but regardless, they showed an increased response rate compared to placebo over 24 months. And then more recently, we've had the 2 non-fibrate PPAR agonists, Elafibranor and Seladelpar, report their results. For Elafibranor, it's the Elative trial. And as we can see here, using the POISE criteria again, 51% of the patients had a biochemical response compared to 4% in the placebo control arm. And then if you look at alkaline phosphatase normalization, 15% of the patients actually achieved normalization compared to none in the placebo group. In general, elafibranor is well tolerated. There's some minor GI effects that are seen in a minority of patients and generally does quite well. And then in the response study of Seladelpar, we see that 61% of the patients achieved a biochemical response compared to 20% in the placebo, and 25% achieved alkaline phosphatase normalization. And over here on the right, we can see the difference in the response rates. And you can see that the decrease in the alkaline phosphatase in all these drugs occurs very early, within 4 weeks. We generally see the response. And again, similar safety with Seladelpar, mild GI side effects, but otherwise well tolerated and safe. Now, there are no studies comparing these head-to-head, so it's really impossible to say one is superior to another. And I think the important thing that we can look at and see is that if we look at the therapeutic response, that is the difference between the treated group and the placebo group, they're pretty similar. And really, I think for us in clinical practice is how far can you expect your alkaline phosphatase to improve? How far will it go down? And we can expect with these drugs, regardless of where we start, we'll get about a 40% reduction in our alkaline phosphatase. So if a patient comes in and their alkaline phosphatase is 500, I would not expect them to necessarily get normal, but even going from 500 to 250 is a big benefit for them. So while we want to get to normal, what we want to get for all our patients at the lowest alkaline phosphatase we can. And so with that, let's move on to our case number 2. This is a 54-year-old woman referred for evaluation of her PBC, of course. She's got celiac disease. She's on the same dose of urso as our other cases. But she was just diagnosed 6 months ago. She's got some mild itch using a numeric rating scale of 2 that we'll hear a little bit more about in the third talk. Some dryness symptoms, but no evidence of advanced liver disease. She's adherent to therapy, and she's got the following liver tests. So her alkaline phosphatase initially started at 500. 6 months into treatment with urso, it's down to 360. Her GGT is similarly dropped. Her bilirubin's unchanged at 1.2. Her platelets are low at 150. She had an ultrasound that shows surface nodularity, same sort of spleen size, and a liver stiffness at 7.2. So let's start with a panel discussion.
I mean, I think this patient, again, if you're thinking of biochemical response, you kind of have reason to start second-line therapy. When do you start, I think, is an important question. I think, do we have to wait for 12 months? I don't think we do. My approach has generally been to talk about patients who I don't think are going to meet normalization or close to normalization pretty quickly up front. You see with the second-line therapies that responses happen very quickly. As you said, at 4 weeks, numbers will improve, and then they generally improve a little bit more, but are sustained at this low level, right? So in the patients that with urso have elevated liver tests ongoing, I talk about the need for second-line therapy pretty quickly up front, and they may not want to start on the first time I talk about it, but I will definitely open that line of discussion at 6 months and start when they're ready thereafter.
I think part of the decision about deciding when to start is second-line therapy, 6 months versus 12 months, is actually the trajectory of the ALK phos decline. So if this is 500 and you see a plateau for the last 3 months, I don't think you're going to get much more waiting 6 months. It's going to hover around there. So it makes sense to have a discussion about starting second-line therapy earlier. There's the data from global PBC about using that ALK phos threshold of greater than 1.9 times upper limit of normal at 6 months. And if you use that at 6 months, you're probably going to accurately treat 89% of your patients by starting second-line therapy earlier as opposed to waiting a year. So you can potentially use a 6-month cutoff earlier. One of the questions that came up from the audience is, especially for the trial entries that you discussed, how do you determine ursodeoxycholic intolerance, and is that just based on patient experience?
Yeah, so that was basically exactly it. It was based on patient tolerance, what they reported, I should say. So there's no specific test for it. I mean, I think we've all experienced it. Certain patients come in and they describe the nausea or other side effects. Sometimes hair loss, which I'm not completely convinced is urso related, but those tend to be the two main ones that lead to intolerance.
Aliya, what would you start for second-line therapy?
What would I start? I mean, I think it's a discussion with patients. We have a spectrum of agents available, and it differs by center, right? So I think in this era, probably a PPAR is your first option for a second-line therapy, and then you sort of discuss pros and cons of whether you pick Elafibranor or Seladelpar. I think in general, as Chris said, you expect about a 40% decline in blood tests, and the differences biochemically between the agents I don't think in the real world will be that different. As we'll talk about, I think symptoms are really important. Pruritus is a really impactful point for patients. And so if you're going to get added benefit with using Seladelpar and itch versus Elafibranor at 80 milligrams, then maybe that's a factor that you think about. But maybe I'll ask you guys. And what about at 3 months? Would you think about starting therapy at 3 months even?
Yeah.
Or what's the difference between 3 months versus 6 months?
So the earliest, I just month ago started a patient after only 4 months.
Really?
She'd come in and it was clear she wasn't going to have an adequate response. There was no reason to wait. She was also symptomatic.
Right.
We were able to get it approved, which is also the important thing.
Right.
But yeah, I don't think we necessarily have to wait 6 to 12 months. You could wait to see if they plateau. There's no rush to treat it sooner. I mean, this is a chronic disease, as you mentioned. But when you have the patient in the office, how many patients do we lose at times and lose that opportunity? So to me, intervening early is more about making sure we get them on the therapy and not kicking the can down the road and then it not getting taken care of. So it's more of a practical issue than anything else.
A related question is, if you don't see a response to one of the PPARs, and this is from the audience, have you switched to another PPAR, and have you been able to demonstrate a response to a different one? I think maybe thinking about patients that you might have had on fenofibrate that you might be switching over could
so personally, my own experience is I have had a few patients that are on fenofibrate and discussed switching them over. Most of them are happy, so I've not done that. Or they've chosen not to do that, I would say. And they've all responded well to the fenofibrate at the time, so.
I agree, but these are like real world questions that are going to emerge, right? And so global PBC is amazing in what they've been able to capture across the globe. And even the FIOCA study, right, has shown that there is dynamics in what patients are treated with over time. And I think we'll learn more about what patients that are switched between PPARs and patients that come off FXR agonists and move to PPARs over time. So personally, I have not switched anyone unless they're having intolerance or there's a reason they're doing poorly or there's a reason to switch. But I think that that's going to be a really important real world question.
And it does seem that you might get a little bit better improvement in the alk-phos there, but there's no downside to it.
Right.
So if your patients are on OCA and they need to switch, there's probably no downside to it.
The so-called like treatment experienced patient, right?
Yeah, exactly.
Thank you to our faculty and many thanks to you, our listeners, for joining us. To hear the other episodes in this program, Innovations in PBC Care, or to follow along with the slides, click the link in the show notes. And to get access to all of our new podcasts, subscribe to the DESERA Clinical Education Medical Specialties channel on your favorite player. Thank you, and we'll see you on the next podcast soon.